Thank you very much. First, I want to thank my hosts who are not here for inviting me to Zagreb and to this meeting, and to bring to your attention this subject, which a lot of my colleagues still don't think it is an important one, and I hope I'll be able to convince you that this is not the case. So we are going to talk about iron. And the story is whether are we saving life or just lowering iron. In other words, is there any indication? Is it a problem in MDS and MPN or not? First of all, just a little bit of information. Most of the iron in the body is in hemoglobin, some in myoglobin, and some in enzyme. There is a very nice iron homeostasis. 1 or 2 milligrams comes in every day, 1 or 2 milligrams comes out every day. And it's going to the various organs here, which you can see. The big problem is that the body is so smart, but one thing he doesn't know. If you have too much iron, the body has no way how to get rid of it. This is okay as long as you have normal iron homeostasis. So, if you are an MDS patient who needs transfusion, if you get 2 units per month or 4 units per month, you can accumulate 100 units of blood in 2 years, in 4 years or in 2 years. Just for your information, 100 units of blood is 20 grams of iron. The normal amount of iron in the body is no more than 3 or 4 grams. So, too much iron. Just to show you, this is iron stain in the liver, which is full of iron. This is in the pancreas. You see a blue pancreas, also full of iron. This is where the excess of iron in one of the organs where it is stored. Now, the problem begins. Iron is usually bound by proteins, transferrin and the storage protein ferritin. If you have too much iron, then it cannot bind iron anymore. So then we start to see free iron species. And the free iron species are first described as non-transferrin bound iron. Then you have the LPI, which is the chelatable redox active component of the NTBI. And you have also label. And you see, I will not, because of the time, I just want to tell you that these are the 2 most important free iron species in the circulation. And you can see here, when you have the transferrin saturation is saturated, then when you can see the labeled pliers by iron, also correlating here with ferritin. So, too much iron, you cannot bind it anymore, free iron. And this is just to show you that the labeled plasma iron in difficult diseases with similar serum ferritin. In other words, already now I'm telling you, serum ferritin is not the real true parameter of how much iron you have. And the labeled plasma iron seems to be much more important, and you see here thalassemia, MDS that we're talking about, yes? And these are the anemias where you have a lot of this free iron. This is the ferritin label, this is ferritin here, and this is the labeled plasma iron, which you see here. Now, so you ask me, as my colleague here said before, so what? So here is the story. If you have too much iron in the plasma, serum, it can go inside the cell, and you have a labeled iron pool, which is the intracellular iron. And this is catalyzing the formation of oxygen-free radicals, reactive oxygen species, but very well-known biochemical reactions, the Haber-Weiss reaction and the Fenton reaction. Bottom line, this is what comes out, hydroxyl-free radical, which is a very toxic radical. And what is it doing? You see, here is the extra. It goes into the cell. You have this labeled iron pool. And then you have, I'll show you in a second, the oxygen-free radicals that you can see here. And you see, this is the label iron pool, intercellular, ROS, reactive oxygen species, hydroxyl radical, which attacks, destroys every part of the cell, mitochondria up to the DNA. That's the story. Free iron, oxygen radicals, damage to the cells. And you can see here that these are the organs which are being affected. Iron in the bone marrow, liver, muscle, endocrine, heart, of course, red cell, white cells. These are all affected by this free iron. And then the outcome, cardiac failure if it's in the heart, cirrhosis up to hepatoma, diabetes, infertility, and other endocrine disorders. This has been well known, described, thalassemia and other diseases. This is quite well known. Now, what about MDS? NTBI level, you see, in MDS, you have higher, this is from our chairman here, Dr. Santini, you see that the MDS patients have more NTBI. In that case, so they have the more NTBI. Now, here you see here. So, and now you see, again, you can ask me, so what? Reactive oxygen species are important. You need them for physiological balance between production and elimination. You need them, the biogen, you need them. But this is controlled by a nice antioxidant system, However, if the balance is tilted, and if you have too much of these oxidants, the one like we talked about, then you might not have enough of these enzymes to protect it. And then low-level oxidative edge is inevitable. But if you have too much of it, then the problem starts. Now, we have found already several years ago that there is more ROS in peripheral blood cells in MDS, both in platelets, in red cells, and in white cells. This is by fluorescent microscopy. And you can see here, ROS, platelets, red cell, and polymorphonuclear. On the other hand, the protective enzyme glutathione, which you see here, is low because it's utilized. You need it in order to control it, and if you don't have too much, then the levels are low. One is up, the other is low. So already, Dr. Bowen already made this formula that you have here, the oxidative stress mechanism in MDS, iron, NTBI, you now know about that, oxygen free radical, DNA damage, and then the bottom line, you start the myelodysplasia. Another, I just want to mention it, this is the protein which is called hepcidin, which controls iron absorption. In 2 words, you can talk hours about it. If you have too much iron, this protein which is synthesized in the level is blocking iron absorption. If you have less iron, you have less hepcidin in order to more iron to go in. Now, there are several changes in hepcidin in MDS. We know it also. There is ineffective erythropoiesis. Ineffective erythropoiesis somehow affects histidine that is going to be less synthesized. If it's less synthesized, more iron is going to be absorbed. And just to show you, in MDS, it's not just a big problem. You see the levels in the different types of MDS, and now Dr. Santini's slide, and you see, there are some variations. It is increased, but this is not, it's a factor, but not a major factor. I just mentioned it. Now, let's talk about non-leukemic causes of death linked to iron overload. And you see this is a study, there are 2 studies here, and you see here a 37 died from cardiac with serum ferritin above 1,000. Cardiac failure more frequent in transfused patients. We heard that before already. So, too much iron, effect is associated with comorbidities, particularly or mainly in the heart. Prevalence, you see prevalence of comorbidities in transfusion-dependent MDS with transfusion, cardiac, diabetes, dyspnea, etc., etc. The more transfusion you have, the more comorbidities you have. And according to the MDS registry, the chelated patients who got rid of their iron had a longer overall survival and time to leukemia transformation, as well as fewer significant death. Iron chelation delays. You see here, this is the abstract of Dr. Lyons, and the paper just came out. Now, what about higher risk MDS and AML progression? Iron is mutagenic, promote progression to AML in mice. You see, you have NTBI, LPI, ROS damage, genomic instability, apoptosis, mutagenesis, MDS. That's a very important factor which has not been studied enough yet. And here is also progression from MDS to AML in irradiated mice. Here you have the mice radiated, and then continued observation of this mouse model suggests that iron is mutagenic in hematopoietic cell and can promote progression of a pre-leukemic state to frank AML. Now, we did a study here when we added iron and a chelator on ROS, label iron pool, and DNA damage parameter eta-hydroxyguanine in normal and MDS culture-derived myelo-monocytic cells. And you can see here, this is the ROS. If you more iron, you have more ROS. If you have the chelator, you have less ROS. This is ROS, label iron pool, DNA damage. In other words, too much iron, more ROS, more label iron pool, and more DNA damage. And this is another assay, the COMET assay, which is another parameter of DNA damage. This is the untreated cells. You give ferrum ammonium sulfate, you see DNA damage. You give the chelator, you have less DNA damage. Again, iron is a player here. All right, chelation. What do we want to do? We want to get rid of iron level, detoxify the effects of free iron, correct DNA damage if possible, and prevent delay, maybe transformation to leukemia. Now, there are many parameters. I'm not going to go over that today. Not only serum ferritin is important, and serum transport separation. There are many ways that you can measure. We talked about hepcidin, the free iron, very important. And now, last but not least, are the MRI technology, which actually tells you how much iron you have in major organs. Okay, I hope I convinced you. Iron is bad for you. So the next step is, when do you start chelation? When do you start chelation, if at all? So here, I'm giving you all kinds of indications from various groups. Just summary of this slide. If you have a ferritin, which is above 1,000, according to some thalassemia study, should not be more than 800. Then is an indication to think of iron chelation, which is equal to about 20 blood transfusion. This is more or less the time we have to start of iron chelation. This is to show you the MRI. Lots of iron in the liver. You can quantitate it. It's a very good, important parameter to see how much iron you have. And this is a summary of 5 studies who studied iron in the heart, which is very important. And you see, not so much, but there is some percentage, 15 to 75% had a lot of iron in the heart, which obviously is bad for you. So it's another story. We think that if you have too much transfusions, like a pathology study many years ago, the more transfusion you have, the more iron in the heart you have. This is an old study, but I think it's an important message. And you see, this is the cardiac complications in MDS. Increased in the transfusion-dependent. You see here, uptake of LPI in the cardiac cells lead labile plasma iron, congestive failure. So it's really bad for you to have iron in the heart, you see? And you see here, mitochondrial production of ROS, ROS production, tissue damage, direct toxicity of ROS in the heart. Bad for you. Okay, chelators, 3 available chelators. Desferal, deferipron, oral, and the last, which is most commonly used today in MDS, is deferasirox. The idea is that if you give a chelator, it goes into the cell, it takes out the iron, it neutralizes the hydroxyl free radical, out she goes, and then it's coming out. The best one, by the way, who's doing it is L1, deferipron. So far, no trials have been done in MDS. We are going to start a trial now. But this is the most effective one to get a lot of iron from inside the cell. We don't want to see this labeled plasma iron. And this is what we want. By the way, you can give a combination. The peripheral during the day, the deferioxamine, which is doing by a needle in a pump at night, and this is the best. But if you don't have any, so you have to give it, you can give the deferoxamine, or you can give the Exjade, which are the ones which are being commonly used. Now, you see the effect of iron chelation in LPI MDS. This is a study of Alan List and Gatterman, and you see very nicely. The mean LPI goes down, both in the American study and also in the German study. That's what we want to achieve. And also we have found out that the label iron pool, that the study that we did, the bad iron in the cell, in red cell and platelets is going out after 3 months of Exjade to 20 MDS patients. And at the same time, you see, this is the LPI, this is the LIP in red cell and in platelets. That's what we want to do. And also we found changes in oxidative stress parameters going down, the protective enzyme going up, the platelets is the same. In the white cells is the same, and there also improvement in the lipid peroxidation of the cell. This is a study which we are going to start now, a protocol with the other chelator, the ferripron, to see if it affects the same way. Now, another thing which has been described that by Mesa et al., that it affects a tumor marker NF-kappa B activity, important by the iron chelator, and another parameter, the mTOR signaling, which is another tumor marker, which also is increased, decreased, following the addition of the chelator. So we also found that there is a differentiation of human leukemic cell, myelo-monocytic. You see CD14, CD15, if you give a iron chelator to these cells, leukemic cells, in a tissue, in a culture. Hepcidin also goes up following iron chelator, deferioxamine, which is good, so less iron will be absorbed. Another advantage of that. So the Brescia study just came out now, potential mechanism induced by the iron chelator deferasirox, mTOR, reduction of ROS, direct effect on the neoplastic of the bone marrow, promoting release of iron from the stores, we talk about that, NF-kappa B, many things that can be induced by this chelator. Now, there are already many studies about survival, but as my colleague Gil will say, they are all retrospective, but still, you cannot ignore it. You see, adequate chelator, this is a French study, much better survival. The German study, improved survival in patients with MDS. AML transformation in this study did not change, but in the LIST study, there was a improved overall survival and a trend to low MRL in patients with low risk. So according to the Florida study, to the Alan Lee study, there's also less transformation into leukemia. Now, another thing which I want to say, the mortality increases, the serum ferritin increases. Please look at this one. Greater mortality was noted in MDS who were transfusion, you see, and this is the one who, I'm sorry, this is the one, the bad transfusion, and the better one who were with less transfusions. So, overall survival, another story. From Lions, you see, chelated for more than 6 months, non-chelator. You cannot ignore these differences. They are there. And also, this is a Spanish study just came out this week. Also, chelated versus non-chelated in 263 patients for more than 3 years. You see, this is chelated, unchelated. This is survival, survival, survival. 3 groups here. Time to cardiac complication, time to acute myeloid leukemia, time to death. Advantages to the iron chelation. Causes of death. This is the Lyons paper which just came out. MDS AML in non-chelator 50.7%, in chelated 40.7%, in chelated more than 6 months 36%. Again, another indication that iron chelation helps. And this is a very interesting, also just came out. Look, all the number of patients here, 5 studies. Not only that you have better survival, but look, erythroid platelets and neutrophil counts went up 21%, 13%, 20%. So there was even a difference in the production of the cells caused by the iron chelation. Look, I'm giving you here 6. This just came out now. And there is a certain percentage who respond, which is another advantage for the iron chelation. And the last but not least, bone marrow transplantation. Look, you see here, this is iron chelator, survival of patients after bone marrow transplantation, much better. We're talking of before, during, and after. Outcome of patients by pre-transplantation, serum ferritin levels, you see, if you have a higher serum ferritin level, you have overall survival, which is better, disease-free survival, which is better. Again, you need to get the patient to transplant if possible with less ferritin. Prognostic impact of pre-transplantation, secondary in patient undergoing allogeneic hematopoiesis, the Gitmo study. Again, you see, this is the chelated, and this is serum ferritin below. You see, again, this is advantage of less iron in bone marrow transplantation. RBC, again, so this, no RBC transfusion dependency, RBC transfusion dependency, leukemia-free survival. This is another study which showed that. And very interesting, last but not least, that the label iron, the non-transferrin, is going up even during induction. This is the Kruger study. When you give the induction for the bone marrow, your cells are released and you have this free iron coming up. And you transfer in saturation, of course. And this is just last slide from Dr. Kruger, just presented in the EBMT, comparison between non-plasma and serum ferritin 95 for allogeneic transplantation. High NTBI, 2-fold increase in the risk of death, 4% increase in bacteremia, 7% in fungal infection. Serum ferritin is not that important. NTBI level increased during conditioning, even when baseline NTBI and serum were normal. Very recent. Conclusion. Current monitoring mainly evaluated serum ferritin and T2 star, and very important, the free iron species. Several retrospectives show better survival. It is possible there might be an indication for treating patients with advanced form of MDS, lowering infection, delaying leukemic transformation. Until results of prospective, which is very difficult to do studies available, we recommend to treat at least patients with documented decrease of NTBI and on LPI in order to ameliorate oxidative stress. Antibody is increased during conditioning of BMT. Iron overload may play in survival of patients after BMT. And there are already papers who are trying to take care of it, even by phlebotomy. I don't care, as long as you get rid of this excess iron. And the last slide is a problem in multi-transfusion patients with low risk. This free iron, which I tried to explain to you, ROS is being done. Therefore, in my mind, if you have free iron in circulation, this is like you have a toxin. If you have too much lead, if you have any other metal poisoning, you get rid of it. Okay? The same applies for iron. If you have free iron, it should be removed, even if my colleague here will tell me that there is still not enough evidence to show that it prolongs survival. I think there is a case. Too much iron is bad for you. If you have it, you should take care of it. Thank you.